Good afternoon, everybody, and welcome to the fifth webinar in our Experts on Air series on high flow oxygen therapy. My name is Caroline Brown from Hamilton Medical, and today we have two familiar faces joining us, Dr. Jens Bräunlich from Germany and our regular guest in this series, Dr. Tommaso Mauri from Italy. They're going to talk about high flow oxygen therapy in hypercapnic respiratory failure. But before they start, just a few quick reminders from me. Your cameras and microphones are switched off, but we'd love you to ask as many questions as possible using the Q&A function. The session is being recorded and a link to the recording will be sent out to you in an email a few days after the event. And now, with no further ado, I'd like to hand over to Tommaso Mauri in the interviewer's seat. Thanks, Tommaso.
Thank you, Caroline. Welcome to everybody. We have the fortune, we are lucky to have Jens Bräunlich here, who is an expert from the University of Leipzig. He is the head of the Department of Respiratory Medicine in Emden, and he studied a lot nasal high flow and published books and papers, especially on this topic of COPD. Hi, Jens, and welcome.
Hi, thank you for the invitation.
So to start, we are used now in this series to have a poll, and the idea is to give the poll, to launch the poll before the expert presentation, because we want to see, to capture, to do a photograph of your real life, real clinical practice. So I will launch the poll now, and there is no right answer. The right answer is your answer, whatever you think is most appropriate for your patient. So we have somewhere to start from. So I launch the poll and you can enter your answer. So in which COPD patient or situation involving a COPD patient do you recommend, do you think it's worth using high flow nasal cannula? In stable COPD patient, during COPD exacerbation, so COPD but with some acute respiratory failure, during exacerbation, but with some signs of severity, so mild hypercapnia, or already on non-invasive ventilation when you have to stop it and alternate, only COPD who fails or don't tolerate an IV, or you don't think it's indicated high flow in COPD patients. So answer your, pick your favorite answers, even more than one. There is no right answer. We think this topic is very open, so it's very nice to have very different answers, because there is not yet much evidence, as Jens will show in a moment. So we have 22 answers. Let's leave it 15 seconds more if you want to add people from the audience, and then I will end and publish the results. So we have 26 answers, and we can close, I think, and I will share the results. So you should see the answer. Jens, do you want to comment?
Yeah, that is very interesting. I'm very happy about that. There are not so much people who have never used it in COPD patients. It makes me really happy, and it reflects very, very good the current evidence about this nasal high flow use in hypercapnia and COPD patients, especially if I see as a pulmonologist the use in stable COPD patients. It makes me very happy, and I think also in mild hypercapnia without any indication for COPD for non-invasive ventilation. This is a really good gap where we can use nasal high flow. I think this reflects very good what we do also.
Okay. Do you agree, maybe also as a connection with the previous webinars, that being the largest, the most chosen answer to alternate on non-invasive ventilation, that is true for all kind of patients, even for hypoxemics? Yeah. We think that going from an NIV to nothing is worse than going to NIV to something, to some high flow. And I think this is very cautious and reasonable from a physiological point of view to use it, to start using it. Okay, if you want to share your presentation, we can go ahead and listen your suggestions and reasoning.
Okay, thank you. So, okay, thank you very much to Hamilton Medical for the invitation to presentation, for my presentation about the use of nasal high flow in hypercapnic respiratory failure this is necessary. These are my conflict of interest in several companies. Also with a nasal high flow device, I have some conflicts. So if we want to think about the nasal high flow as a ventilatory support device, we can have a look to the current recommendation here from the British Thoracic Society and also from the European Respiratory Society. And you see here very clear, there are indications for non-invasive ventilation with a high evidence, especially in acidotic hypercapnic COPD exacerbations. If you have a neuromuscular disease and you have an acidosis in these patients, and if you have a very obese patient, you can use non-invasive ventilation with a high evidence, and is strongly recommended to do this. But if you use the non-invasive ventilation, for instance, if you look at the European Respiratory Society guidelines in de novo respiratory failure, you have no recommendation made. So therefore, you have nothing what you can do despite of invasive mechanical ventilation or oxygen in these patients. And here in the British Thoracic Society guideline, you see from 2015 that non-invasive ventilation is not indicated if you have a patient with asthma or the pneumonia. And this is really a gap where we have a problem to use non-invasive supporting devices in these patients. But on the other hand, you have also problems to use this in this treatment group with a strong recommendation, for instance, acidotic hypercapnic respiratory failure because of COPD exacerbation. You have a failure rate in very good Cochrane database reviews from 11 up to 30%, where you cannot use a non-invasive ventilation, the bite of a nice use setting and something for the patient to sleep. And as a pulmonologist, I have also a look to patients with chronic stable hypercapnia. And if you look at the literature in these patients, you see a failure rate or intolerant rate in these COPD patients above 35% in these patients. And I think there is a really urgent need to have an additional non-invasive ventilatory support device. And I think nasal high flow can fill this gap. And you see here some more physiological preliminary studies from our own group from 2013, and we tried about 1 hour and 2 hours in stable hypercapnic COPD patients. You see it's on the left side that we use it with success regarding the decarboxylation in this patient. So we can reduce hypercapnia in these patients, and we had also a preliminary study, you see it on the right side, with only a few patients with the use of nasal high flow over 6 weeks, and after them non-invasive ventilation over 6 weeks. And we have documented in this very mild hypercapnic respiratory stable COPD patients that we can reduce hypercapnia. And that was for us the beginning to understand nasal high flow not only as a peak flow coverage or a mild PEEP generation device or an oxygenation device. This is an ongoing discussion. So we started to understand nasal high flow as a ventilation support device. And that was the focus of our next step and our interest, especially in Germany in my university. And I will point out 2 mechanisms of action. You know, there are several mechanisms of action. You have generation of a PEEP, peak flow coverage. You have no such much entrainment from the room air, not oxygenated room air, and so on, no mucociliary clearance. I will point out 2 effects. And one effect is the effect of the washout. And you see here the very interesting study from Möller published several years ago in non-breathing patients. That's very important because we don't know how deep we can wash out with a nasal high flow device. In these patients, they stopped breathing during the experiment. But you see here very good, if you fill the krypton gas in the nasopharynx in these patients, and then you use a nasal high flow device, you can wash out very effectively these room. And especially you can eliminate the CO2 in the expiration, and in the next inspiration you have a lower CO2 in this room. You see this very good in the tracheal CO2 in the in the graphic. And you see also, if you use a higher flow rate in these patients to eliminate CO2 with this aim, you have also a higher elimination of CO2. So you can optimize nasal high flow if you want to decarboxylate such a patient. But you can also do a little bit more. You can also play with the leakage in this patient. And this is an experiment of from our own group. We had a very simple mechanism. We used the prongs in both knees with 20 liters per minute. After them, we increased the flow rate to 40 liters per minute in the stable patients. And after them, we increased the leakage in our patients and used also for the device, 40 liters per minute, but there came only 20 liters per minute in one knee with one prong, and the other knee was open. What we found was very interesting. We could also influence the decarboxylation in this patient. In this graphic, you see that this is the capillary PCO2, what we have measured. If you use it from 20 liters to 30 liters per minute in both knees, you have an increase in PCO2. We have learned this from the Möller study. But if you increase the leakage in our patients and decrease in reality the flow, you have also a higher elimination of CO2 in our patients. And I think you must keep this in mind. If you use nasal high flow device and have no success for a decarboxylation, but you have a patient, you can use the nasal high flow with non-invasive and he is stable enough, you can also try to increase the leakage in these patients to decarboxylate the patient and have increase in pH. And there is another very important mechanism for me, very often not really clear communicated. That is, if you give the patients with a decrease in alveolar ventilation, and this is a very nice study from Berselli from the ERG published series before, have a reduction in alveolar ventilation, and you give these patients a more support to overcoming the anatomical dead space in this patient, you can decrease the work of breathing. And this is also true in patients with acute hypercapnic respiratory failure and also in chronic patients. And I think you must think about this, that you have a very good ventilation support in our patients. So let's have a short look to studies, and there are not so much studies like in hypoxemic patients. And we started this study in 2011 in stable hypercapnic COPD patients, and we looked for the decrease in PCO2. I'm a pulmonologist, that's why I look for stable patients also. And we randomized these patients to the sequence to first use 6 weeks nasal high flow and after them non-invasive ventilation. And in the other arm, we used first the non-invasive ventilation. This is the standard therapy in stable COPD patient regarding lesser mortality or lesser exacerbation. And after them, we used nasal high flow. And we found, and the limitation of our study is we used a flow of 20 liters per minute. Do we think it was 2011? We had no study by Tommaso Mauri and no study by Jean-Pierre Fratt. We had no idea what's the best flow rate in our patients, but we found very good that we can decrease PCO2 in our patients without any difference or significant difference compared to non-invasive ventilation. When you see regarding the phenotyping, you know also not every device works in every patient. You see also we have patients who have a good responder regarding the decarboxylation with non-invasive ventilation, but you have on the other hand patients who have very good idea to decarboxylate during nasal high flow device. This was the first randomized controlled trials in these patients. And have a short look also to a more pulmonologist problem, the exacerbation or prevention of exacerbation. And there's a preprint published several weeks ago about the use of a nasal high flow device at home compared to long-term oxygen therapy. And what they have found is that if you use a nasal high flow device and long-term oxygen therapy compared to long-term oxygen therapy, you can decrease significant the exacerbation rate. And this is very important of these patients because the survival in frequent exacerbations is reduced. Let's have a look to a few data about acute hypercapnic patients. And you see in our own study here, we have only used the nasal high flow in patients who have no non-invasive ventilation tolerance. It was only observational, no randomized controlled trial or something else. And we found that we can reduce over this time the PCO2 and increase the pH in our patient. And especially on the right side, you can see patients with a clear recommendation to use non-invasive ventilation. We can also treat these patients very successful. But these are preliminary data. We are looking for better data about this fact. But there are also some data from Italy, from Andrea Cottichiani, published in 2020. They compared in a non-inferiority design, non-invasive ventilation and nasal high flow in hypercapnic COPD patients, and they found no non-inferiority in this small study. They had some idea that NIV could be a little bit better, but I think this is the first sign that nasal high flow is effective in hypercapnic respiratory failure, but we need a little bit more data about this. And to do more evidence, to bring more evidence to this point, we conducted also a trial. There are a little bit more trial in the world about this effect, about patients with an acute hypercapnic acidotic respiratory failure, and you want to try it in 720 patients to use nasal high flow compared to non-invasive ventilation. And the outcome parameter will be the treatment failure, mortality, and so on. And I think we can say at the moment we have effects in hypercapnic or ventilatory insufficient patients with a nasal high flow device, but we need a little bit more data to learn how we can use, in which patient we can use, and how effective is this. Okay, thank you very much.
Thank you, Jens. We can jump to the question because there are already a lot. Let's start from the mechanism. So you showed that maybe the air leak around the cannula sides is relevant for CO2 washout. So would you recommend the thing that you did to use just one cannula and one nares? Do you use it clinically, or do you recommend maybe smaller cannula size?
No. Yeah, exactly. This is a perfect question. I have my presentation was too long. That's why I would address this point. There is a study published from Pinkham at the moment in the Journal of Applied Physiology. They measured in a model study that you can increase some effects of a nasal high flow device if you use in the same patients a bigger cannula size. But this is not true. Yeah, if you use a higher flow, you have more effective. You know it's better than I, that with higher pressure, decreased walk of breathing, and so on. But if you use it in 20 liter or 50 liter per minute, this high flow, and you change the cannula from a small cannula to a bigger cannula, you have no changes in respiratory rate, airway pressure, and also in PCO2. We have measured this several years before. We have not published this data, but only changing the cannula size, you can only measure differences in a model study, but not in reality.
Okay, but do you use the one to put just one nares?
Yeah, sometimes I have a patient who I don't want to intubate, yeah, and he must be stable, and I can say we can do this. I use this in a CF patient. I use this only in one, and it works.
You close the other. That is important.
Yeah.
So there are two questions on flow rate. The first is what is the maximum flow you recommend for a COPD? And another that it goes with this is how do you titrate flow in COPD? Because it's not much. In hypoxemia is nice. You look at the saturation. Now here, what do you use as a parameter?
Yeah, it depends a little bit what you mean. If you have an acute exacerbation of COPD, you can go very high. They tolerate this. Yeah, they have they are very hungry for air. Yeah, this is no problem. I would see this also like in hypoxemic patients. You must give these patients a lot of air. Yeah, but if you use this in patients with a stable hypercapnia, and we use this very often, I have, in my opinion, I would start with 25, 30 liter, and the most tolerated flow in these stable patients is 35, for my opinion. I think there is a range from 30 to 40 liter per minute in the stable patients. But on the other hand, an acute patient needs a lot.
Do you use a Borg scale?
Sorry?
Do you use a Borg scale?
No.
No, no. Okay.
No.
So if you have a patient with COPD and requiring an IV, do you think that high flow first or an IV first and high flow to alternate?
Okay, we have no idea what alternating brings. Yeah, from a physiological or clinical point of view, it makes sense to use as alternating non-invasive ventilation in nasal high flow. But our evidence in nasal high flow, in acute exacerbation, for instance, or acidotic patient is very low. So I would first recommend to use non-invasive ventilation. And if you have problems regarding the intolerance, you have a stable patient, but you have no real success, the pH is at the same measurement and the PCO2 is also not better, I would recommend to use a nasal high flow device in a very good setting, of course, where you can measure very closely. Yes, but I would do this, and we do this every day. Yeah, in stable patients, it depends a little bit what you need with this patient. If the patient don't tolerate non-invasive ventilation, I try also a nasal high flow device in this patient with the same aims regarding the PCO2 bettering in some short respiratory questionnaire or the severe respiratory insufficiency score. Yeah.
Okay. And in terms of monitoring, here, so CO2 is not very much measured in this patient because you don't perform many ABGs, you don't put many arterial lines unless they are very severe. But you don't use the ROX index SpO2 in this patient. So what is your monitoring? Do you assess CO2 regularly? Do you use other parameters to look at the response? Is this patient responding to the support?
Yeah, at the first, I would ever look at the respiratory rate. If you look at the patients, you have a very, very fast answer. Yeah, the respiratory rate goes in 1 minute, 2 minutes down if you were very successful in this patient, and you get also the feedback from the patient. I have no so much hungry to air. Yeah, I think this is a very fast way to look at this. In COPD patients, it's a little bit difficult regarding the oxygenation. Yes, they comes with a very high hypercapnia, and you don't want an hypoxemia. That's why you use only few oxygen. So I cannot imagine that the ROX index is very good. Very often, in 50%, the patients come to the hospital with a hyperoxemia. And that's the problem. What would you calculate from the baseline with the ROX index? So I would ever look at the PCO2 at this patient, and a little bit faster, I would look to the respiratory rate.
Okay, so respiratory rate is the main guidance that you would use.
Yeah.
And what are the criteria that you use to start an IV and an IV intubation? So for these COPD patients, sometimes you don't want to intubate them because they are old. If they have multiple intubation, it's a very negative predictive value. So what is the pH that you tolerate, the CO2 that you tolerate during treatment?
It depends a little bit on the patient, yes. If you have no clear criteria, it's a clinical improvement what you must use in this patient, especially with COPD. You have also patients, I spoke with patients with a pH of 7.1, yeah, and they say to me, oh, well, it's fine. It's also a little bit worse than the other one. And so I must look a little bit, this was also the problem in our study, the study design, when should you intubate, when should you change to the other treatment to have a good parameter. I think we should not accept worsening in these patients. This is very important. And on the other hand, you must look at the patients about the deterioration and the Glasgow Coma scale and so on to make a decision in these patients. This is very important to look at the patient. I have no clear line for this.
Okay, so if you have a patient on an IV, you need to interrupt, for example, for eating. But do you do the same with high flow, or, for example, you leave them eating on high flow in your practice?
If the patient is very sick and he needs a break, I would use a nasal high flow device.
During eating too, you don't interrupt?
Yes, yes.
Okay. And in more stable patient, another question from Hannah is, you mentioned like home therapy, this is more like stable patients, maybe using similarly to NIV during sleep, do you think this is something near? I have no, I work in the ICU, is very different field for me, but for stable home patient or ambulatory patient, or do you think iFlow is the near future for long-term therapy support?
Perhaps. There are very interesting data comes from the bronchiectasis, the respiratory support, not published yet, and they have similar data, and they found really good success to use a nasal high flow device. I would not say that non-invasive ventilation is out in the future, of course not, but in patients, especially in these 30 patients who don't have a support because of the intolerance of non-invasive ventilation, they could benefit from nasal high flow. And I do it in the same way on every day. If a patient have no tolerance to non-invasive ventilation and they have the same success with a nasal high flow device regarding the decrease in PCO2, I would recommend to use it at home at the same time, in absence of any data about this, but it would use it also the 6 hours per night, for instance, and I have a good feeling about this. Yes, and our data are good.
Okay, so do you use any sedation? So no, my question is different. Truly speaking, if you have a patient on NIV or in some sedation, and you interrupt, you do a break with iFlow, do you keep the sedation? You think there is some sedation needed for tolerating iFlow in this patient?
I think you don't need a sedation in this patient. I have never seen, because of the higher flow, that you need a sedation. There were other problems in this patient. I think not, but I'm not sure about the fact that nasal high flow could have problems if you sedate this patient. But I don't know exactly. No, but for my opinion, I would not use a sedation in this patient. It's not necessary. Yeah.
Okay, so someone is asking, what is the endpoint for a home iFlow study? So you would recommend iFlow use at home, but what is the clinical endpoint? The reduce exacerbation, what does it mean? To not to take influenza, to avoid infections, or it's more like the pulmonary function declining less in a less steeper way?
For use at home, you have some landmark studies, like the study by Kernlein. He reduced the mortality, and we have the other study from Patrick Murphy. He reduced the exacerbation and the admission at home. Yeah, and this is our aim, to show the same. And we measured in our RCT the reduction in PCO2 as a secondary or tertiary endpoint to the other endpoints, but there are now up to now 3 studies who have shown that you can reduce the exacerbation rate. Yes, and this should be the aim. If you can reduce it, it was the best player do you have. Yeah.
Okay, so there is a question on let's say personalized use. Can you predict a patient who will benefit, a COPD patient who will benefit from iFlow? So there are signs that personalize, like higher flow, higher respiratory rate, I don't know.
Yeah, we had some secondary studies. In our own study, we looked also for the patients who benefits more from non-invasive ventilation or nasal high flow, but in our COPD patients, I have no idea.
No idea.
No
okay.
idea.
So another question I have is most of these patients needs aerosol, because COPD patients do a lot of aerosol. How do you do that with iFlow?
Yeah, it works very good, and we have a lot of data about this point. We have also published this study several years before, and we used it with a normal nebulizer, and we used it with the nasal high flow device, and had a more increase in FEV1 in our study. And there are also a lot of studies from I think James Fink published in the last years about aerosols during a nasal high flow device. And we have the idea, but we have a low evidence, that the aerosol inbringing in our COPD patients is more effective if you use a nasal high flow device. For
you don't interrupt the treatment for aerosol.
I would not do this.
Okay, do you increase the dose of the aerosol drug because there is more dispersion?
No,
you give the same rate. Okay, and is another question is, do you keep the same humidification with aerosol, the mixing with the dry, or you decrease the temperature, for example?
No, I don't decrease the temperature. In these works from the more physiological groups, they use the aerosolation chamber before the nasal high flow device. I think this is the trick in this point. You have a little bit lower droplets in this case, and so you can bring in it a little bit better. It depends not so much on the humidity in this patient. It depends a little bit more on the flow rate and the position of the humidifier and the aerosol generating chamber.
Okay, we have arrived to the end. Let's let that one last question. How do you wean off the high flow from a COPD patient? You just stop, you decrease flow?
No. I would decrease the flow and would interrupt a little bit more breaks in these patients, but I would decrease at the first step, and I think the patients want this also, the flow rate.
Okay, I think we are done. Thank you very much, Jens.
That's it for today, everybody. We hope you enjoyed it, and thank you very much for taking part. And of course, a big thank you to our two experts for their time today. Be sure to check your inbox later next week for the link to the recording, as well as additional answers to any questions that we haven't addressed today. The last webinar in this series will take place on May 5th. So if you haven't already signed up for that, just follow the link that's been placed in the chat. Thanks again, everybody, and we look forward to seeing you again soon. Bye for now.
Bye, thank you.
Bye, thank you.